Hey everybody, this is Miss Goolsby here. Today we're going to cover Chapter 9, which is Pre-Examination, Pre-Analytical Considerations. Here are the objectives for you to get out of this chapter. There are only 3. Number 1 is demonstrate basic knowledge of the pre-examination, pre-analytical variables that influence laboratory test results. Define associated terminology and identify the test most affected by each one variable. Number 2, discuss problem areas associated with site selection, including various vascular access sites and devices, and explain what to do when they are encountered. And lastly, number 3, describe how to handle patient complications and conditions pertaining to blood collection, address procedural error risk and specimen quality concerns, and analyze reasons for failure to draw blood. So overall, we are going to look at a couple of topics. Pre-examination is the phase of testing that begins when the test is ordered and ends when testing begins. So as a phlebotomist, the pre-examination, pre-analytical phase, that's where you are as a phlebotomist. The doctor or the nurse practitioner orders the test. The requisitions come through with the barcodes. Whatever specimens need to be drawn, that is you that goes to do it. And that ends once you get that specimen back to the lab, and then the lab tech starts running the test on it. That is the analytical phase once you get it back and hand it over. But as a phlebotomist, you work in this pre-analytical, pre-examination phase. The skills needed in a phlebotomist, you've got to have the technical skills to perform the blood draw and the ability to recognize pre-analytical factors and address them, like any issues that might come up. Topics that are in this chapter are the physiological variables, problem venipuncture sites, types of VADs, patient complications and conditions, procedural errors, specimen quality issues, and troubleshooting failed venipunctures. So starting out with the references. Most tests are performed to confirm health or to screen for or diagnose or monitor somebody's disease. To be properly evaluated, these test results need to be compared with results of expected healthy individuals. So that is how they know whether a result is low or high based off of comparing it with healthy individuals, what their results would be. So the result values for most tests are established using specimens from normal healthy people. They're going to vary a little bit person to person. So this is why you end up with a control range or a reference range. You've got high and low limits. This is what is called a reference range or a reference interval. That is the range of values in healthy people with high and low limits. Test results within that range are said to be normal. Most reference ranges for healthy fasting individuals are also included in this so that they don't have to worry about whether someone has eaten something to affect any of the values. Some tests have reference ranges that are age specific or specific to certain illnesses or disorders like diabetes, and in that case, those will be compared to those. If a specimen has been compromised and the results are not valid, a physician could make a diagnosis or decision based on incorrect information and jeopardize that patient's care. So this is why you need an accurate specimen to turn into the lab. Look at the blue box on this slide. It says one way that a physician evaluates a patient's test results is by comparing them to reference ranges and, if available, previous results on the same patient. So you need to know what a delta check is. Delta check means it is comparing the value that they get today with that individual patient's value. So let's say that 4 days ago, this patient had an 800 glucose. And today, 4 days later, their glucose was 70, which is normal. What that would do is that flags the lab to let them double check that that was correctly drawn on the right patient. Now, in 4 days' time, that can come down. But let's say that 2 hours ago, the patient was 800 glucose. They had another one ran, and now it's 70. Then that would definitely flag an alarm. That they can change that result that much in 2 hours is very unlikely. But that is what a delta check is. Basal state. This refers to the resting metabolic state of the body early in the morning after fasting for approximately 12 hours. A basal state specimen is ideal for establishing reference ranges on inpatients because the effects of diet, exercise, and other controllable factors on the test results are minimized or even eliminated. Basal state is influenced by the physiological patient variables such as age, gender, and conditions of the body that cannot be eliminated. Looking up here now one more time on position, we're going down the list. Body position before and during blood collection can influence specimen composition. So if you go from lying down on your back to upright or standing, that causes body fluids to filter into the tissues, which decreases plasma volume in an adult by nearly 10%. So there are certain things like aldosterone, bilirubin, blood cells, calcium, total cholesterol, iron, protein, and renin that increases when that happens. The concentration of your freely diffusible components are not affected by postural changes. A significant increase in potassium occurs within 30 minutes of standing. This has been attributed to the release of intracellular potassium from your muscle, the muscle that it takes to stand up. You want to collect lipid profiles in a consistent manner after the patient has been either lying down or sitting quietly for a minimum of 5 minutes to minimize postural effects on the sample. The same position should be used each time the patient is tested. So if this is ran a couple of different times. Patients should sit for 20 minutes or more to eliminate postural effects on some blood tests, and even longer before potassium and phosphate are ran. If you call an outpatient into the drawing area, have them sit in the drawing chair while paperwork that is related to the draw is readied. That can help minimize the effects on postural changes in some analytes. You need to allow them not to sit in the waiting area, but call them back and let them sit in the chair. Pregnancy, moving on. Pregnancy can cause some changes. For example, increases in body fluid that happen in pregnancy. This can have a diluting effect on red blood cells, leading to lower red blood cell counts. Smoking. Some blood components are affected by the nicotine absorbed through smoking. Patients who smoke before specimen collection may have an increased cholesterol, cortisol, glucose, growth hormone, and triglyceride levels, as well as white blood cell counts. Glucose levels in patients with diabetes are especially affected by smoking. Studies have shown that nicotine is the primary cause of elevated glucose levels in smokers who are diabetic. Smoking can also affect your body's immune system, lowering the concentration of your immunoglobulins, which are your antibodies. Chronic smoking can also result in increased red blood cell and hemoglobin levels as a result of decreased pulmonary function. That's your body's way of trying to bring in more red cells to pull the oxygen through the body if the lungs are not working properly. Skin puncture specimens may be difficult to obtain from smokers because of impaired circulation in their fingertips. Moving down to stress. Emotional stress like anxiety, fear, or trauma can cause a short-lived elevation in white blood cell counts. For example, infants crying have demonstrated a marked increase in their white blood cell counts, but it returns to normal within 1 hour after that infant stopped crying. Stress is also known to decrease serum iron levels and increase ACTH and cortisol. Environmental factors such as temperature and humidity, those can affect test values by influencing the composition of body fluids. So excessive sweating without fluid replacement, that can cause hemoconcentration. Specimens being transported from off-site locations, they do require protection from temperature extremes to preserve the specimen integrity, like you have couriers that bring in specimens from outpatient locations, and they have to be protected from the temperatures in the environment. Laboratory temperature and humidity are closely monitored to maintain specimen integrity and ensure that the equipment functions properly. Moving on to problem sites. You want to avoid burned, scarred, and tattooed areas. Veins may be difficult to palpate or penetrate in a burned and scarred area. Healed burn sites and other areas with extensive scarring may have impaired circulation that could lead to erroneous test results. Newly burned areas are very painful and susceptible to infection, so you don't want to use those. Freshly tattooed areas may have an undetected infection or be more susceptible to infection. Tattoos may also mask problem areas and impair the ability to detect bruising, rashes, and other reactions to phlebotomy. If you have no choice but to draw in an area with a tattoo, try to insert the needle in a spot that does not contain dye. Damaged veins. Some patients' veins feel hard and cord-like. That's because they are partially or completely occluded or obstructed. These veins may be sclerosed or hardened or thrombosed or clotted from the effects of inflammation, disease, or chemotherapy drugs. Scarring caused by numerous venipunctures that results from regular blood donors, people with chronic illnesses, and illegal intravenous drug users can also harden veins. Damaged veins are difficult to penetrate. They may yield erroneous test results because of impaired blood flow and should be avoided. If possible, use another site or draw below the damaged veins. Edema is swelling caused by abnormal accumulation of fluid in the tissues. It sometimes results when fluid from an IV infiltrates the tissues. It's also a common problem after mastectomy. Specimens collected from edematous areas may yield inaccurate test results owing to contamination with tissue fluid. Veins are also harder to locate. The stretched tissue is often fragile and more easily injured by the tourniquet and antiseptic. Healing may be prolonged in these areas, so choose another site if you can. If phlebotomists are on early morning rounds in hospitals or nursing homes, you guys are often the first to notice edema from infiltrated IVs. And if you see that swelling in that area, you should alert their nurse that's in charge of them. A hematoma is a swelling or mass of blood that can be caused by blood leaking from a blood vessel during and following venipuncture. A large bruise eventually spreads over the surrounding area. Here is a picture of one. Venipuncture through an existing hematoma is painful. If the draw is difficult, there is also the possibility that hemolyzed blood from the hematoma could be drawn into the tube or syringe, resulting in a specimen that is now unsuitable to be tested. Venipuncture in the immediate area surrounding a hematoma may also be painful. To ensure that you do not collect contaminated blood from that area, never perform a venipuncture through a hematoma. If there is no alternative site, perform the venipuncture below the hematoma to ensure the collection of free-flowing blood. Never draw blood from an arm on the same side as a mastectomy. Lymph node removal, which is typically part of the procedure, can cause lymphostasis, which is obstruction or stoppage of normal lymph flow. Impaired lymph flow makes the arm susceptible to swelling called lymphedema and to infection. Lymphedema can cause range of motion limitations and pain, weakness, and stiffness in the extremity. It's also been suggested that the effects of lymphostasis could change blood composition and also lead to inaccurate test results. So when a patient has a mastectomy, you choose the other arm. Well, what if the mastectomy has been performed on both sides, or there is no suitable site for blood collection other than an arm on the mastectomy side? If that is the case, make note somewhere that you must obtain written permission from the patient's physician for the blood draw on an arm that a mastectomy has occurred on. Okay, you must have written permission from their doctor. Obesity. Obese, which means extremely overweight, patients often present a challenge to the phlebotomist. Veins of obese patients may be deep and difficult to find. Proper tourniquet selection and application is the first step. Typical strap tourniquets are normally around 18 inches long. They may be too short if someone has large arms without rolling and twisting and being uncomfortably tight. They do make bariatric tourniquets. If you do not have bariatric tourniquets, then you can take 2 tourniquets and tie them together to make one. To locate a vein on a patient who is obese, check the AC area, antecubital area first. Obese patients often have a double crease in the antecubital area with an easily palpable median cubital vein in that area. Between the 2 creases, if no vein is easily visible or palpable on tourniquet application, ask the patient what sites have been successful for past blood draws. Most patients who are difficult draws know what sites work best, so ask your patient. If the patient has never had blood drawn before or does not remember, try the cephalic vein. To locate the cephalic vein, rotate the patient's arm medially so the hand is prone. In this position, the weight of excess tissue pulls downward, making the cephalic vein easier to feel and penetrate with the needle. Paralysis is the loss of muscle function. Paralysis can be temporary or permanent. Most paralysis is the result of a stroke or an injury to the spinal cord. Other causes include nerve damage and autoimmune disorders such as muscular dystrophy and ALS. Avoid drawing blood from a paralyzed arm if possible. It should not be assumed that there is no feeling in a paralyzed arm. There is lack of feeling only if there is also sensory damage. So don't think if you stick a patient in their paralyzed arm they can't feel it, because a lot of the times they can. When the lower part of the body and both legs are paralyzed, that is called paraplegia. If both the arms and legs are paralyzed, that is called quadriplegia. Okay, vascular access devices. These are tubing and other devices that are designed to allow entry to veins or arteries. They are often used for patients who require frequent venous or arterial access. They are most commonly used for administration of medications, fluids, blood products, and sometimes blood collection. As a general rule, though, venipuncture should not be performed on an extremity with a VAD. Follow your facility's protocol. Only nurses and other specially trained personnel are permitted to draw blood specimens from vascular access devices, or VADs. The phlebotomist typically assists by supplying the appropriate tubes, and if a syringe is used, transferring the blood to the tubes using a syringe transfer device. IV lines. Intravenous means pertaining to or within a vein. Blood specimens should not be drawn from an arm with an IV. If possible, the specimens can be contaminated or diluted with IV fluid. causing erroneous and misleading test results. This is especially true if specimens are drawn above the IV, so make note to never draw above an IV. When a patient has an IV in only one arm, draw the blood specimen from the other arm. If a patient has IVs in both arms, draw the blood specimen distal or below one of the IVs. If both arms are unavailable for venipuncture, some specimens can be collected by capillary puncture. If a specimen cannot be collected by capillary puncture, it may have to be collected from an IV by a nurse or other specially trained person. If you have to draw below an IV, there is a certain procedure you have to do, and in your textbook on page 327, it is procedure 9-1. This is the procedure to perform a venipuncture below an IV that you must follow. Number 1, ask the patient's nurse to turn off the IV for at least 2 minutes prior to collection. Number 2, apply the tourniquet distal to the IV. Number 3, select a venipuncture site distal to the IV and the tourniquet. Number 4, perform the venipuncture in a different vein than the one with the IV if possible. Number 5, ask the nurse to restart the IV after the specimen has been collected. Number 6, document that the specimen was collected below an IV. Indicate the type of fluid in the IV and identify which arm was used. IV catheter locks. This is a needleless connection device in the form of a stopcock or cap that is connected to the hub of a catheter or cannula by a short length of IV tubing. It has a diaphragm that provides access for administering medication or drawing blood. A lock is often placed in a vein in the lower arm above the back of the wrist and can be left in place for up to 48 hours. To keep it from clotting, the device is filled and flushed with saline and sometimes heparin. A device filled with saline is called a saline lock. One filled with heparin is called a heparin lock or hep lock. Risk associated with using heparin and its higher cost have resulted in the saline lock becoming the type that's most commonly used. Arterial line. An arterial line or art line is a catheter placed in an artery. It is most commonly located in the radial artery of the wrist. It's typically used to provide accurate and continuous measurement of a patient's blood pressure. It may also be used to collect blood gases and other specimens and for the administration of drugs such as dopamine. Never apply a tourniquet or perform venipuncture on an arm with an arterial line in it. Arteriovenous shunt, fistula, or graft. AV shunt bypasses the capillaries and forces arterial blood directly into a vein. A shunt created for dialysis commonly joins the radial artery and cephalic vein above the wrist on the underside of the arm. A dialysis shunt created by direct permanent fusion of the artery and vein is called an AV fistula and is visible as a large bulging section of the vein. A fistula has become the most common type of shunt used for dialysis. A shunt created using a piece of vein or tubing to form a loop from the artery to the vein that can be seen under the skin is called an AV graft. When palpated, a shunt has a distinctive buzzing sensation called a thrill that is the result of the pressure of the arterial blood flow meeting the flow of the vein. A shunt is a dialysis patient's lifeline. You never, ever, ever perform venipuncture or apply a blood pressure cuff or tourniquet on an arm with any type of shunt. This is a picture of an arm with an AV shunt and a fistula. AV shunt is in the top one and a fistula is in the top and a graft is in the bottom in B. A blood sampling device. This is a needleless closed device that is sometimes connected to an arterial or central venous catheter, CVC, for specific purposes of collecting blood specimens. These devices are said to reduce the chance of infection, prevent needle sticks, and minimize waste associated with line draws. A central vascular access device, also called an indwelling line, consists of tubing inserted into a main vein or artery. They are primarily used for administering fluids and medications, monitoring pressures, and drawing blood. Having a CVAD is practical for patients who need IV access for an extended period and is beneficial for patients who do not have easily accessible veins. Only specially trained personnel should access a CVAD to draw blood. However, as with other VADs, the phlebotomist may assist by transferring the specimen to the appropriate tubes, but you are not to draw out of this device. Most CVADs are routinely flushed with heparin or saline to reduce the risk of thrombosis. A CVC, or central venous line, is inserted into a large vein such as the subclavian vein and advanced into the superior vena cava, proximal to the right atrium. An implanted port is attached to an indwelling line that is surgically implanted under the skin and most commonly located in the upper chest or arm. This device is located by palpating the skin and assessed by inserting a special needle through the skin into the self-sealing wall of the chamber. It's not normally covered with a bandage when it's not in use. It's just right under the skin. A PICC line is a peripherally inserted central catheter. It does not require surgical insertion and is typically placed in an antecubital vein just above or below the antecubital fossa. Never apply a tourniquet or perform venipuncture above a PICC line because the line could be damaged by the tourniquet pressure or needle puncture. There is a picture of a central venous catheter. This is a picture of an implanted port. This is a picture of a PICC line, or a peripherally inserted central catheter. Patient complications and conditions. A phlebotomist must be aware of any previous complications like fainting the patient may have had with a blood draw and any condition such as an allergy that must be addressed before or after blood collection. You must also be prepared for unexpected reactions before, during, or after the draw, such as marked pain or excessive bleeding, and you need to be able to react quickly and appropriately. Allergies to equipment and supplies. Occasionally, the phlebotomist will encounter patients who are allergic to one or more of the supplies or equipment used in blood collection. Some may have an adhesive allergy. This means they have an allergic reaction to the glue used in adhesive bandages. A solution to that is to place a clean folded gauze square over the site and wrap it with Coban instead of giving them a Band-Aid. Do not wrap it too tightly and be certain to instruct the patient to remove it in 15 minutes. Antiseptic allergy. Occasionally you'll have a patient allergic to the antiseptic in skin preparation. Alternative skin antiseptics should be available for such cases. Latex allergy. This involves a reaction to certain substances in natural rubber latex. There should be a warning sign on the door to the room of any patient known to have a severe latex allergy, and it is vital that no items made of latex be brought into the room, whether collecting blood from the patient or a roommate. Patients with known allergies often wear special armbands or have allergy-specific warnings posted outside their door. Excessive bleeding. Normally a patient will stop bleeding within a few minutes. Some patients, especially those on aspirin or anticoagulant therapy, may take longer to stop bleeding. Always maintain pressure over the site until bleeding stops, If the bleeding continues after 5 minutes, notify the nurse in charge of the patient. Never apply a pressure bandage instead of maintaining pressure until bleeding has stopped, and do not dismiss an outpatient or leave an inpatient until bleeding has stopped or the appropriate personnel have taken charge of the situation. Fainting. The medical term for fainting is syncope. This is described as a loss of consciousness and postural tone, which means the ability to maintain upright posture, resulting from insufficient blood flow to the brain. It can last for only a few seconds or as long as half an hour. Any patient that has the potential to faint before, during, immediately following, or shortly after venipuncture. Some patients become faint at just the thought or sight of their blood being drawn, especially if they're ill or have been fasting for an extended period. Other contributing factors include anemia, dehydration, emotional problems, fatigue, hypoglycemia, hyperventilation, medications, nausea, needle phobia, and poor or compromised breathing. Sudden faintness or loss of consciousness caused by a nervous system response to abrupt pain, stress, or trauma is a type of reflex syncope called vasovagal syncope. This is a picture of a phlebotomist caring for a patient who feels faint. Routinely ask your patients if they've ever had a problem with venipuncture. A patient who has felt faint or fainted on any prior venipuncture will usually tell you this information right away. Ask a patient with a history of fainting to lie down for the procedure, no matter how long ago the fainting occurred. A patient who appears to be extremely nervous, hyperventilates, or expresses fear or anxiety over the procedure should be considered at risk for fainting, nausea, or vomiting. Outpatients are more likely to faint because they are usually sitting up during venipuncture. Routinely ask patients how they're doing during a draw, watch for signs of fainting, and be prepared to protect them from falling. Signs to watch for as a phlebotomist when you're doing a blood draw include pallor or paleness, perspiration, and hyperventilation. Others include an indication from the patient they are experiencing spinning, dizziness, lightheadedness, nausea, a darkening or constricting or tunnel vision, and sound fading into the background. Fainting can occur without any warning, so never turn your back on a patient, especially after the draw is over. Stay within one step of the patient so you can react quickly to prevent a fall should they faint. Do not use ammonia inhalants that they used to use back in the day to revive patients who have fainted, because they can have unwanted side effects like respiratory distress in an asthmatic person. Have a patient who has fainted remain in the area for at least 15 minutes. After regaining consciousness, instruct the patient to not operate a vehicle for at least 30 minutes. Document the incident in case of future litigation. If a urine test is ordered along with blood test on an outpatient, ask the patient to collect the urine specimen first. Otherwise, the patient could become faint after the venipuncture and pass out in the restroom with the door locked. It is not unusual for a patient to experience nausea before, during, and after a blood draw. The patient may tell you they're feeling nauseous or show signs that are similar to fainting, such as becoming pale or having beads of sweat appear on their forehead. Do not attempt a blood draw until the experience subsides. Discontinue a blood draw if you are in progress, if you are in the middle of it. If a patient vomits during venipuncture, terminate the procedure immediately. Reassure the patient and make them feel as comfortable as possible. A small amount of pain is normally associated with routine venipuncture and capillary puncture. Try to put your patients at ease before blood collection to help them relax, which can make the procedure less painful. Warn the patient before needle insertion to help avoid a startle reflex. Allow the alcohol to dry completely before needle insertion to avoid causing a stinging sensation. Excessive deep, blind, or lateral redirection of the needle is considered probing. It can be very painful to the patient, risk injury to arteries, nerves, and other tissues, and should never be attempted. Never probe in the patient. Marked or extreme pain, numbness of the arm, a burning or electric shock sensation or pain that radiates up or down the arm during a venipuncture indicates nerve involvement and requires immediate removal of the needle. If pain persists after needle removal, consult with the patient's physician or other appropriate personnel and document the incident. Application of an ice pack to the site after needle removal can help prevent or reduce inflammation associated with nerve involvement. If you sense that the patient is in pain, the patient complains of marked or extreme pain, or the patient asks you to remove the needle for any reason, terminate the venipuncture immediately, even if there are no other signs of nerve injury. Petechiae. These are tiny, non-raised red, purple, or brownish spots that appear on the patient's skin when a tourniquet is applied. The spots are minute drops of blood that escape the capillaries and come to the surface of the skin below the tourniquet. Causes include capillary wall defects, coagulation abnormalities such as platelet defects, and thrombocytopenia, which means no platelets, or low platelets, Certain medications like aspirin and some infectious inflammatory diseases can also cause this. They are not normally an indication that the phlebotomist has used incorrect technique unless the tourniquet has been incorrectly applied and is exceedingly tight. However, they are an indication that the venipuncture site may bleed excessively. Petechiae are generally less than 3 millimeters in diameter. Non-raised blood spots larger than 5 millimeters are called ecchymosis. Seizures and convulsions. Seizures have been known to occur during venipuncture, although there's no evidence that they can be caused by venipuncture. In the rare event a patient has a seizure or goes into convulsions during the blood collection, discontinue the draw immediately. Hold pressure over the site without restricting the patient's movement. Call for help to ease the patient to the floor and turn them on one side to keep the airway clear. Put something soft under their head. Loosen it if they have a tie, collar button, or anything else restrictive that could make their breathing difficult. Try to protect the patient from self-injury without completely restricting movement of the extremities. Time the seizure and notify the appropriate first aid personnel. Do not attempt to put anything into the patient's mouth to hold the tongue down. Contrary to popular belief, a person having a seizure cannot swallow their tongue. Procedural error risk. Venipuncture is an invasive procedure, and risks are involved when it is performed. A competent phlebotomist is aware of these risks and prevents problems from happening or quickly addresses those that do occur to prevent the problem from getting worse. Hematoma formation and bruising. Hematoma is the most common complication of venipuncture. It is caused by blood leaking into the tissues during or following venipuncture and is identified by rapid swelling at, near, or beneath the venipuncture site. A rapidly forming hematoma may indicate that an artery has been hit accidentally. Discontinue the draw immediately and apply direct forceful pressure to the puncture site for 3 to 5 minutes until active bleeding ceases. Iatrogenic anemia. Iatrogenic is an adjective used to describe an adverse condition brought on by the effects of treatment. Blood loss through blood removed for testing is called iatrogenic blood loss. Removing blood on a regular basis or in large quantities can lead to iatrogenic anemia in some patients, especially infants. Blood loss to a point at which life cannot be sustained is called exsanguination. A primary reason for blood transfusion in neonatal intensive care unit patients is replacement of blood lost through testing. Inadvertent arterial puncture is rare when proper venipuncture procedures are followed. It is most often associated with deep or blind probing, especially in areas near the basilic vein, which is close to the brachial artery. If an inadvertent arterial puncture goes undetected, leakage and accumulation of blood in the area can result in compression injury to a nearby nerve, Such injuries are often permanent and can lead to lawsuits. If arterial puncture is suspected when you're doing a blood draw, terminate the venipuncture immediately and apply direct forceful pressure to the site 3 to 5 minutes or until bleeding stops. Infection. Although a rare occurrence, infection at the site following venipuncture does happen. The risk of infection can be minimized by using proper aseptic technique, which includes the following. Don't open tape or bandages ahead of time. Don't preload needles onto tube holders ahead of time. Don't touch needle insertion site after sterilizing it. Minimize time between needle cap removal and venipuncture, and remind the patient to keep the bandage on at least 15 minutes. Nerve injury. Although relatively rare, nerve injury is a serious phlebotomy complication that can result in permanent damage to motor or sensory nerve function of the arm or hand and the probability of a lawsuit. There are two basic types of nerve injury that can be negative consequences of venipuncture procedures. One involves the needle directly contacting the nerve in the form of a nick or puncture, and the other results from a compression injury to the nerve rather than direct contact by the needle. A nick or puncture to a nerve is usually the result of poor technique, such as improper site vein selection, inserting the needle too deep or quickly, excessive or lateral redirection of the needle, or blind probing while attempting venipuncture. Another cause is startle reflex movement by the patient who has not been warned of imminent needle insertion. If initial needle insertion does not result in successful vein entry, and slight forward or backward movement of the needle or use of a new tube does not result in blood flow, remove the needle and attempt venipuncture at an alternate site, preferably the opposite arm. Extreme pain, a burning or electric shock sensation, numbness of the arm, and pain that radiates up or down their arm are all signs of nerve involvement, and any one of them requires immediate termination of the venipuncture. Continuing the draw if nerve damage has occurred can make it worse. Do not ask the patient if you should stop the draw. The patient may not understand the seriousness of the situation and allow you to continue. That picture is called a claw hand. That is an ulnar nerve injury that occurred to that patient. Sometimes signs of nerve involvement appear during a blood draw, even though the tubes are filling with blood. When this happens, it is tempting to finish collecting the specimens. The standard of care, however, based on CLSI standards, is to immediately terminate the venipuncture. Reflux of additive. In rare instances, it is possible for blood to reflux or flow back into the patient's vein from the collection tube during the venipuncture procedure. Reflux is thought to be caused by a normal variation in pressure in the patient's vein or the sudden drop in pressure on the vein when the tourniquet is released. If the blood is flowing slowly into the anticoagulant tube and you feel the need to mix the tube to prevent clotting, remove it from the holder, mix it, and quickly replace it in the holder to continue the draw. Ask an outpatient to lean forward and extend the arm downward over the chair to achieve proper positioning. Raise the head of the bed, extend the patient's arm over the side of the bed, or support the arm with a rolled towel or folded pillow to help achieve proper positioning of a patient who is laying down. Vein damage. Properly performed, an occasional venipuncture will not impair the patency of a patient's vein. Numerous venipunctures in the same area over an extended period, however, will eventually cause a buildup of scar tissue and increase the difficulty of performing subsequent venipunctures. Blind probing and improper technique when redirecting the needle can also damage veins and impair vein patency. Procedural error in specimen quality. The quality of a blood specimen can be compromised by improper collection techniques. Hemoconcentration is one problem. Tourniquet application causes localized venous stasis or stagnation of the normal venous blood flow. This is why, these changes that happen, this hemoconcentration, they can occur within 1 minute of tourniquet application. That's slight. But if you leave that tourniquet on for more than a minute, then it can lead to marked changes, which means that some of their values will be out. Hand or fist pumping also causes that problem. Hemolysis, damage to or destruction of red cells. This is where hemoglobin escapes into the fluid part of the specimen. Hemolysis results when these red cells are damaged. In that case, the serum will be pink or red, depending on how hemolyzed it is. Partially filled tubes. You must fill ETS tubes until the normal amount of vacuum is exhausted. Failure to do so results in a partially filled tube referred to as a short draw. Some phlebotomists underfill tubes to save time. This practice is never recommended. You also never pour two partially filled additive tubes together to fill one tube because this will affect the blood to additive ratio. Specimen contamination is typically inadvertent and generally the result of improper technique or carelessness, such as allowing the alcohol residue, fingerprints, glove powder, baby powder, urine on the newborn screening samples. This can lead to specimen rejection. Getting glove powder on blood films or capillary specimens, dripping perspiration into capillary specimens, following improper antiseptic procedure, or using the wrong antiseptic. These are all things that can cause problems. The FDA has banned the use of powder gloves, though, so we don't have that risk anymore. Also, wrong or expired collection tubes. Drawing a specimen in the wrong tube can affect test results and jeopardize patient safety if the error is not caught before testing. Additives in expired tubes may not work properly. Expired anticoagulants may allow the formation of microclots. Expired tubes may have also lost vacuum, which will result in short draws. So routinely check the tube expiration dates and discard tubes that are expired. Troubleshooting failed venipunctures. Failure to initially draw blood during a venipuncture attempt can be caused by several procedural errors. If you fail to obtain blood after inserting the needle, stop all needle movement, remain calm so that you can clearly analyze and assess the situation and correct the problem, which could be any one of the situations described. The first one we're going to look at is tube position. Tube position is important. Check the tube to see that it is properly seated and that the needle in the tube holder has penetrated the tube stopper. Needle position. Insert the needle so that the bevel is correctly positioned within the vein. That is critical to success of the venipuncture. If the needle is not inserted far enough, it may not penetrate the vein at all. Partially out of the skin, like the bevel is partially out of the skin, the tube is going to lose its vacuum when it's engaged and filled with blood, even if the bevel is mostly in the vein. A bevel partially into the vein. If the needle is not inserted deeply enough, the bevel may be beneath the skin but only partially through the upper vein wall. If the needle bevel partially through the vein, bevel partially through the vein, not into the vein. If the needle is inserted too deeply, too quickly, or at an angle that is too steep, part of the bevel may go through the lower wall of the vein. If the bevel is completely through the vein, if it's gone too deep, the bevel may penetrate all the way through the vein. So in that case, you may get a small spurt of blood into the tube as the bevel goes through the vein, or there may be no blood flow at all. The bevel is against a vein wall. Blood flow will be impaired if the needle bevel is up against the upper or lower wall of the vein. This can happen if the needle angle is wrong. Bevel is in a valve. Because veins have valves, it is possible the needle bevel could hit a valve during a blood draw. The needle bevel could be in the middle of the lumen where it should be and still come in contact with the valve tissue. Needle is beside the vein. Vein walls are sometimes tough, and if a vein is not anchored well with the thumb, it may roll or move away slightly, and the needle may slip to the side of the vein instead of into it. Often the needle ends up beside the vein and slightly under it as well. If this happens, disengage the tube to preserve the vacuum. Withdraw the needle slightly until just the bevel is under the skin. Anchor the vein securely and redirect the needle into the vein and re-engage the tube. If redirection is unsuccessful, discontinue the draw and choose a new site. Do not search or probe for the vein or move the needle in a lateral or sideways direction to find it. When phlebotomists miss veins, they often tell patients that they have veins that roll. This leads patients to mistakenly believe that there is a problem with their veins, when more than likely the problem is the phlebotomist technique. Veins can roll somewhat, but it is up to the phlebotomist to anchor them well so they do not roll. And lastly, undetermined needle position. If you cannot determine the needle position and the previously described situations don't help, try a new tube. If a new tube does not work, discontinue the draw and select a new site, preferably on the opposite arm if there's nothing to prevent its use. Do not blindly probe ever in a patient, though it's painful. This is showing correct needle position where blood can flow freely into the needle. This is right directly in the middle of lumen of the vein. This is showing a needle not inserted far enough, so the needle never enters the vein, so this is where you get nothing back. This is where the needle bevel is partially out of the skin, so you're going to lose tube vacuum. It's going to be sucking air, basically. This is where the needle bevel is partially into the vein, and what's going to happen there is you're going to get a hematoma in the patient because you're only partially in there in that tube. In the vein. This one is showing the needle bevel partially through the vein, so you're going to get that flash of blood and then nothing. So it's still going to leak out into the tissue, causing them a hematoma, and you're not in the vein anymore. And this is where the needle bevel is completely through the vein and you got no blood flow obtained whatsoever. So you get nothing, and also the patient is not getting a hematoma though, because you're not anywhere near the vein. This is showing a picture of where the needle bevel is up against the upper wall of the vein. So see, it's kind of like it suctions and blood can't go out. This is where the needle bevel is against the lower vein of the wall. So in this case, the bevel was not up. So it's wrong when you're going in the first place. You had a bevel down, and that's suctioning to the bottom of the vein. This is a picture of the needle bevel penetrating the valve, which prevents blood flow. So you may be in the vein, but now you're in a valve. This is where the needle is beside the vein. It caused when the vein rolls to the side, nobody held that vein down. The phlebotomist didn't hold the vein down to keep it from rolling, and you went beside it. This is a picture of a collapsed vein, which prevents blood flow despite being the correct needle position. In this case, this had nothing to do with the phlebotomist. A vein can collapse despite the correct needle position. When it collapses, the walls draw together temporarily, shutting off blood flow. This can happen if the vacuum draw of a tube or the pressure created by pulling on a syringe plunger is too much for the vein, like if it's suctioning it too hard. A vein can also collapse if the tourniquet is tied too tightly or too close to the venipuncture site. In this case, blood cannot be replaced as quickly as it is withdrawn, causing the vein to collapse. In addition, veins sometimes collapse when the tourniquet is removed during the draw. This is often the case in elderly patients whose veins are fragile and collapse more easily anyway. Tube vacuum. A tube can lose its vacuum during a venipuncture if the needle bevel is not completely under the skin. Tubes can also lose vacuum during shipping and handling when they bump one another in trays, if they're dropped, or if they're pushed too far onto the needle before venipuncture. If you suspect that a tube has lost its vacuum, try using a new one. If you fail to establish blood flow during a draw and repositioning the needle does not help, try using a new tube before giving up on the draw, because it could just be a vacuum problem. Lastly, here are the NACLS entry-level competencies. We covered all of these. You should be okay with all of these. As always, you know how to reach me for questions. Thank you for listening, and I will talk to you next time.